Good afternoon, everyone. My name is Eszter Szőke, and my PhD thesis title is Diagnosing and Preventing Dysphagia Associated Complications in Tracheostomized Critically Ill Patients. I'm a PhD student here, and I'm a speech therapist at Kiskola Semmelweis Hospital at Neurology and Intensive Care Departments. My mission is speech therapists and physicians working side by side for their patients. And my mission is to improving the quality of life of tracheostomized patients by reducing aspiration-related complications. I have two ongoing projects. The first one is comparing the modified Evans blue dye test of fiberoptic endoscopic evaluation of swallowing in diagnosing aspiration in tracheostomized critically ill patients. The problem is tracheostomy is frequent in the intensive care units with a high rate of dysphagia and aspiration. It can cause pneumonia, dehydration, and, for example, prolonged hospital care or a slower recovery too. Pneumonia incidence is higher if screening for dysphagia lacks. What we know about the aspiration diagnostics. In the first picture, you can see the FEES, which is a gold standard for the non-tracheostomized patients, and it's an invasive method to diagnose dysphagia. In the second picture, you can see the blue dye test, which one is the most frequently used in the intensive care unit, and it's a non-invasive method. The missing link is the quality of the evidence of the blue dye test versus the FEES in tracheostomized patients. And the aim is defining whether the modified blue dye test or the FEES is the most reliable and feasible diagnostic method in tracheostomized critically ill patients. Our clinical question is the blue dye test as accurate as FEES in assessing aspiration in tracheostomized critically ill patients? You can see there our peer framework. The patients are tracheostomized critically ill patients. The index test is the blue dye test, the reference test is the FEES, and the diagnosis is the aspiration. Our hypothesis is modified Evans blue dye test is not inferior to FEES in diagnostic accuracy. The clinical implication, dissemination of the blue dye test for all tracheostomized patients on all intensive care units. You can see there our systematic search on 3 databases. You can see the results and my search key too. Finally, we have 5+1 eligible full text. +1 means it came from a manual selection. So now we finished with the data extraction, so let me show you our preliminary analysis. You can see there 2 forest plots about our main outcomes, the sensitivity and the specificity of the blue dye test. In the analysis, we involved 6 articles, which are all of them are observational studies. You can see them on the left side. Let me start with the sensitivity of the blue dye test. Sensitivity means when the blue dye test can correctly identify the patients who are truly positive, so they really have aspiration. You can see the modified Evans blue dye test sensitivity is 0.64, which means that 1 out of 3 cases maybe. The test tells us the truth, so the patient has aspiration. About the specificity of the blue dye test, specificity means the modified blue dye test can correctly identify the patients who are truly negative, so they don't have aspiration. We see the results. The test specificity is 0.89, so this means that 9 out of 10 patients the test tells us the truth, so the patients really don't have aspiration. We can see that the specificity of the blue dye test is better than the sensitivity. We can see there are outliers, for example, the Filho, Warnecke, and the Belfaschi. About that, we found differences in the method and the population and in the time frame. My second project is validating the Guggling Swallowing Screening test in tracheostomized patients. As I mentioned, dysphagia is frequent in the intensive care units and in the neurology departments too. We have several screening tests. For example, the Guggling Swallowing Screening test, which is an easy test to diagnose dysphagia. It can be used by nurses and speech therapists too, and it's validated in the intensive care unit to screening dysphagia following extubation. What we can know about the GUSS, it's a direct screening test. We give the patient several consistency of food and liquid, and if the patient coughs or his or her voice changes, it means they have aspiration. The missing link is are critical care nurses and physicians as reliable as speech and language therapists in GUSS. So the aim is assessing inter-rater reliability of the GUSS in the intensive care unit and assessing reliability of the GUSS compared to the blue dye test in tracheostomized patients. The clinical question: is the GUSS test reliable regardless of the professionals applying it? The population is the tracheostomized patients weaned from respirator. The index test is the GUSS test performed by the speech therapist and expert. The reference test is the blue dye test performed by the speech therapist, and the diagnosis is the aspiration. Our hypothesis is the intensive care nurses and physicians as reliable as speech therapists in GUSS, and GUSS as reliable as the blue dye test. Our clinical and research implication is easy to perform GUSS can spread as reliable diagnostic tool for aspiration in tracheostomized patients in the intensive care unit. In summary, you can see there the planned submission dates, and I would like to thank you for your attention, and I would like to finish my presentation with Mary Shelley. The beginning is always today.
Have to congratulate you.
Thank
it's a
you.
very great job. If I remember well, you said the FEES is the gold standard therapy, but why are you investigating in the blue dye test?
Thank you for your question. It's a very good question. As I told you, the FEES is an invasive method to diagnose dysphagia, and the blue dye test is a non-invasive. I think the blue dye test it's easier because you just give the patient colored food or liquid and see if you see this means the patient has aspiration, and it's cheaper, and it can perform by the nurses or the speech therapists too. But the fees is a little bit more expensive because we need an endoscope to do this method, and you have to be a specific knowledge to use the endoscope to diagnose dysphagia.
Thank you for your answer.
Thank you, Eszter. Excellent talk and also excellent job. Thank you very much. My question is about the first project.
Yes.
So according to your results, which test should I use in my clinical practice? The blue dye test or the FEES?
I tried both of them. Good question. I would use both of them because if the blue dye test says the patient has no aspiration, we can check it with the FEES too. But for the patient, the blue dye test is better because the endoscope is a little bit, it's not good for the patient, the feeling. Thank you.
Congratulations on your presentation. Since we have such time, I would like to ask a bit global question that in your vision, you mentioned that you want to the speech therapist and the doctors to work together. What is the actual situation in Hungary and even in Kiskunhalas, or is there any other places that you know maybe?
Oh, thank you for your question. As my experience, I can tell you that sometimes it's hard because the nurses and the speech therapist sometimes has a disagreement about the patient swallowing or feeding. That's because the nurses don't know the methods how to diagnose dysphagia, and for them sometimes it's a new thing. I told you in an easier way, but I think the most hospitals are thinking about the diagnostic of the aspiration and dysphagia. So, yes.
I would have just one question regarding your second topic.
Yes.
So in there you mentioned that you want to check the diagnostic accuracy of the speech therapist compared to the physicians as well. So do you think there would be articles that in which the fees is used first by a physician, then the fees is used by a speech therapist in the next round, because that's how you can check the diagnostic accuracy of the speech therapists?
I still don't know. I know that some articles are right about the inter-rater reliability, but I have to check it.
Thank you.
Thank you.